In the investigation, in the CBC, you will find platelet dysfunction, neutropenia, and leukocyte defect. Very important. It's like in the exam hall, you will not be given a child who is actively GI bleeding, but the examiner might ask you, if the child is GI bleeding, what are the steps you want to continue. Sometimes you might get some difficulty while examining such babies, but you have to give instruction, you have to make them comfortable, okay? Thalassemia, the important clues for the thalassemia: general inspection, the hands, what you expect in case of thalassemia. If the child, this chronic hemolytic disease children is in UK, definitely you might get a portacath, that is a catheter that is placed here. The children who gets lots of antibiotic and regular medication or regular blood transfusion, usually they have. In abdomen, desferoxamine mark. This is very important in case of thalassemia. Sometimes you might get this. There can be periumbilical patches of depigmentation because desferoxamine is given in the upper abdomen subcutaneously. Okay. Scar of splenectomy, laparoscopic scar for cholecystectomy or splenectomy. So in case of hereditary spherocytosis, sickle cell, in case of thalassemia, they can have gallstone and eventually got cholecystectomy, so that you might get some scar regarding this. Hepatomegaly with splenectomy scar can be present, in ascites can be present, okay? Now come to the discussion part. Definitely at first point they can ask you about the causes of hepatosplenomegaly. These are in general the causes of hepatosplenomegaly, but I would recommend you, whenever you get a patient of chronic hemolytic disease, tell those names first. According to the patient, these patient related DDs, please tell them first, then go to the other DDs, okay? DDs of chronic hemolytic anemia, memorize these things: beta thalassemia, sickle cell thalassemia, early sickle cell disease, spherocytosis, hereditary spherocytosis, G6PD. What are the causes of hepatomegaly in beta thalassemia? Due to extramedullary hemopoiesis, anemic heart failure, infection from frequent transfusion. That can be hepatitis B, hepatitis. What is the mode of inheritance and problem with beta thalassemia? So mode of inheritance is autosomal recessive. Chromosome number 11 is responsible for that. In case of the problem, that is deficient synthesis of either alpha or beta chain of hemoglobin, present with progressive hemolytic anemia during the second 6 months of life. What investigation can be diagnosed antenatally or on neonatal screening? CBC showing microcytic hypochromic anemia. PBF will show poikilocytes, target cell, nucleated red cell. Electrophoresis will have fetal hemoglobin 90%, no adult hemoglobin, and normal hemoglobin A2. Genetic testing, ferritin level, thyroid function test, these are common. And bilirubin level, urine analysis, skull x-ray showing hair on an end appearance due to widening of the diploid spaces. Management plan. For the management, hypertransfusion regimen, regular blood transfusion using leukocyte depletion blood monthly to maintain the hemoglobin above 10 gram per deciliter. We will transfuse if the hemoglobin is less than 6 or 7, cardiac compromise related to anemia. Chelating therapy with vitamin C 20 mg daily to enhance the effect. Increase urinary excretion of iron more than 20 mg per kg per day. Commence when the ferritin reaches to 800 to 1000 microgram or after 12 to 15 transfusion. Okay. Folic acid supplementation every day, splenectomy to reduce the transfusion requirement, bone marrow transplantation is curative management, gene therapy and limited access to that date, and genetic counseling. These are the management plan. Along with that, you can tell about some multidisciplinary team approach. So you can say, I would like to treat her as under multidisciplinary team. I would like to involve pediatrician, pediatric hematologist, cardiologist, surgeon, the faculty genetic testing, genetist, the faculties that are needed for thalassemia. Types and side effect of iron chelating agent. Very important. Always you will get question from here. So in this book, this has been written so nicely. The number 1 iron chelating agent is desferoxamine. It should be given 5 nights per week. via central line or subcutaneous infusion over 8 to 12 hours. The acute side effect can be locally pain, induration, fever, flashing, tachycardia, hypotension, and some chronic side effect like predisposition to Yersinia infection, night blindness, cataract, blurred vision, deafness, sensorineural deafness, acute respiratory distress syndrome, osteoporosis, leukopenia, thrombocytopenia. Okay. Contraindication of desferoxamine agent are renal impairment because its secretion by kidney is needed. Number 2 is deferriprone. Deferriprone is effective in case of cardiac siderosis. Okay. Side effects are GIT upset, neutropenia, thrombocytopenia, arthropathy, teratogenicity. Deferricerox effective in liver and heart siderosis. Okay. Effective in liver and heart siderosis.